have to admit I'm more emotional than I was before. I'm actually from Rhode Island as well. I have lived more years of my life with pain than I haven't. I also come from a family of alcoholics, and I've been faced with the dilemma of sitting in an office with a provider who cares a great deal about me but has no idea what's going to work for me, and going through this maze of treatments, trial and error treatments for months, weeks, years actually, to find something that works. I don't want anyone to have to go through what he has. I don't think any of us do. I don't want anyone to have to go through what I've had to do. And we all know, I think, and admit we're in a mess right now, and I already stated why I think majorly that is because we have grossly underfunded research on pain. I think we could have prevented a lot of what we're dealing with right now if we were using opioids in a very limited capacity for the right reasons. And I'm not blaming the clinical community. We have a lack of safe and effective therapies for people that have chronic pain. And they're faced with the dilemma when they have someone sitting in front of them of what do I do, what's going to work for them, who's at risk, who isn't. I've heard a lot of similarities across these issues today. We're dealing both with complex brain and neurologic conditions that involve many other body systems, the endocrine system, the immune system. They have many different contributing factors: sleep, mood, social activity, function, cognition, family support, housing. All of these issues equally affect them. They're both serious epidemics. They both deserve attention. They're both horrifically stigmatizing. And I've heard a lot of heterogeneity among these groups, both in diagnostic subgroups as well as treatment heterogeneity. And I think the challenge facing the committee and all of us that are working in this area right now is to understand and really dive deep on all of these subgroups and to not make or push blanket policies for all of the groups uniformly. Someone who's on opioids right now and has been for a very long period of time, maybe they need to be treated differently than someone who hasn't even begun using opioids. Someone who has a high risk profile needs to be assessed and treated differently. There's a lot of different groups that we're talking about here. And I think as we move towards the future, we all agree that, as Dr. Wolf eloquently pointed out today, we need a major investment in research on pain to understand all of the subtypes and mechanisms of pain, to understand, to engage in translational and clinical research, to bring mechanism-based treatments to market and to the clinician's office. And only then do I feel like we'll really be able to develop best practices. How do we develop best practices when we don't know what works best? It's really trial and error right now. And we can talk about compassion and empathy and empowering patients, but until we actually have evidence to inform a clinician and a patient as to what their options are and what's going to work for them at the best without increasing risk, how do patients and providers partner to make shared decisions about their care in an informed way? And then, we talk about having options or replacing the use of opioids with other therapies right now. And the problem is that while we can do that, and some of those options do work a lot better for some people, insurance companies don't reimburse for these strategies, and payers are a major group that needs to be brought to the table. As I mentioned earlier with Dr. Shurtleff, when we are encouraged to try integrative care, we don't know which to try. We don't know which modality might work, might not work. All of them usually are out of pocket. And so we really need to bring that group. They're a vital stakeholder that needs to be here. There's so many decisional dilemmas that are faced by clinicians and patients because of this. So as we move forward, we really, as we advance a research effort and the translational and clinical effort, we really need to then translate that into educational and clinical tools for healthcare providers. We can advance science to have knowledge, and that's wonderful, but it's not going to help a single patient unless we have translational efforts. Clinicians are pressed for time. We need tools that are effective in helping them understand what type of pain they're looking at and how to effectively determine what's going to work for that patient. And in addition to pharmacologic and integrative care, something that wasn't discussed or brought up today was devices and new technologies like virtual therapy, and that's certainly going to play a role as we move forward. And just lastly, I want to say and recognize the FDA and the IOM, the National Academies, for including patients in the process. We met with the FDA last week, and their new device division is actually requiring each of their employees to meet with patients one-on-one, to understand the real-life dilemmas that they're experiencing, the issues that they face with devices, and whether it's devices or analgesics or research or whatever it is, we really need to bring all stakeholders to the table, and we appreciate being included in the process. Thank you.